Ophthalmology and NCOA for this virtual presentation event. Special thanks to Jayantan sir, our judges Suhas sir, Rajendra Prasad sir, and Shubha ma'am for accepting our invitation and coming over for this session. Thanks to Dr. Vaishnavi and Pratibha for organizing things and getting things underway. This is the first competitive virtual event that we have tried. So we had a lot of glitches and time was a constraint. If there are any faults, I take full responsibility, and all praise goes to our team for organizing this conference quite wonderfully. As of now, it's going well. Hope and pray it goes fine. The results will be announced around 3 o'clock after all sessions are over. The YouTube link for that will be shared separately. I'd like to introduce our moderator for today, Dr. Jayantan Soundrapandian from KSI Hospital, Erode. Sir is a pediatric ophthalmologist. His knowledge and acumen in cataract and refractive surgery is outstanding. A good friend of mine, an excellent academician. His talks and his sessions are always filled in most conferences. He has given many talks in international conferences also. So he's a managing committee member of Tamil Nadu Ophthalmic Association. Welcome, Dr. Jayantan. Over to you. The floor is yours. Thank you, Jayantan.
Thank you so much, Dr. Pratik. It's so nice of you to introduce me in a nice way. So is my screen visible? Adi, can you see my screen?
Yes, Jayantan, it's visible.
Fine. So I would like to welcome you all for this TNOA free paper session on comprehensive ophthalmology. Thank you so much for joining us today. Thank you for the team, TNOA, President, Secretary, MCOA, and the wonderful organizing team of Madras Icon. So I think has given me a nice introduction. Next is Dr. Pratibha Devi, who is going to be the hall in charge of this session, and Dr. Vaishnavi is going to be coordinating. So if any of the presenters has any of the glitches in any issues, just do a private chat to one of us. So I am happy to introduce our today's judges. Dr. A. Rajendra Prasad sir. Sir did his MBBS DO MS from Madurai Medical College, then entered the government service at 97, and he was assistant professor and retired as a HOD at Coimbatore Medical College. Currently, he is a professor at Karuna Medical College at Palakkad district. He has a wide knowledge of teaching the undergraduates for 20 years and postgraduates for the past 13 years. Welcome, sir.
Thank you.
Professor Suhas Prabhakar. Sir is a medical director, professor, and HOD of the Department of Ophthalmology in Sri Ramachandra Medical College, Chennai. He is a member of the International Forum of Teachers in UNESCO Chair in Bioethics. And all the presenters know that sir is a postgraduate external examiner and a PhD guide for a longer time. Warm welcome to you, sir.
Thank you, sir. Thank you so much.
Next is Dr. Shubha madam. Ma'am has done her MBBS from KMG in 2003, completed ophthalmology in RI, did a long-term fellowship in medical retina from Shankar Nethralaya, and currently associate professor of Sri Balaji Medical College and Hospital, Chennai, and the joint secretary of Tambram. Welcome, ma'am.
Thank you, sir.
This is going to be the order for the day. Presenters, kindly note your order and be ready with your presentations. So the general rule, Dr. Adik has given clearly multiple times, but it's my duty to just go ahead with it. The time duration is going to be just 4 minutes, followed by a 1 minute question answer session only by the judges. Follow your time limit strictly. Your screen will be stopped automatically. In case if you finish early, try to stop your screen and allow for the question answer session to be followed. Follow the order and be ready for your turn. If there is any technical issue, please contact one of us. And, we are ready to go. All the best to all the presenters. Dr. Pratik, we are fine. With the first presenter right now.
You can call the presenter.
The first presenter is going to be Dr. I have a request for everyone. Mute your audios, please, because there's a lot of echo going on around. Kindly mute your audios so that only the presenter can actually present, so the judges can actually hear it in a clear way. Okay, Dr. Uma Maheshwari, free paper number FP177. You can start your presentation. Your time starts now.
Respected members of faculties, a very good morning. I'm here to present a research titled Regional Anesthesia and Cataract Surgery, Why Suffer Pain with Peribulbar Block? Anesthesia care for ophthalmic surgical procedures. Balances goals of patient comfort with safety and an optimal outcome in a highly cost-conscious environment. The ideal anesthesia for a surgery would be that one provides adequate pain relief, easy to administer, and have minimal complications. It is necessary to make the anesthetic technique patient-friendly, safe, effective, and economically feasible. A variety of local anesthetic techniques have been developed and refined. Retrobulbar anesthesia was initially used, which was replaced by peribulbar anesthesia. Both techniques can have serious needle-related complications. Subtenuous anesthesia is gaining popularity as it provides quicker onset of anesthesia, better analgesia, good compliance, and faster patient rehabilitation. The aim of my study was to compare the safety and efficacy of subtenuous over peribulbar block to provide an optimal anesthesia for cataract surgery by phacoemulsification. The inclusion criteria was patient aged above 30 years with uncomplicated cataract admitted for elective phacoemulsification. Exclusion criteria were patients below 35 years, one-eyed patients, traumatic or complicated cataract, patients with bleeding disorders or impaired mental status, patients refusing local anesthesia and having allergic to local anesthetic drugs. Observational comparative study was conducted among 158 patients who underwent cataract surgery by phaco under regional anesthesia. A complete ophthalmic examination, including best corrected visual acuity, cataract grading, and dilated fundus examination was done. Preoperative evaluation and anesthetic fitness were obtained. The parameters which were analyzed were time of onset of ocular akinesia, analgesia at various intervals, and minor complications such as chemosis and subconjunctival hemorrhage. The pain score was assessed using a 11-point numerical pain reporting scale. This is the statistical analysis which was used. Among 158 patients, 79 received peribulbar anesthesia, 79 received subtenuous. Mean age in the peribulbar and the subtenuous anesthesia group was 65.54 and 64.23 respectively, as shown in this graph. With respect to gender distribution, the distribution was almost similar in both the groups. The distribution of the study population was similar in both groups with respect to age and gender. Analgesia assessment, subtenuous had a low pain score in which 85% of the patient had no pain during administration as seen in this graph, whereas in peribulbar it was 65% had moderate pain during administration. This is a tableau column showing the analgesia which is achieved during various intervals, whereas analgesia which is achieved during and post-surgery was similar in both techniques. The ocular akinesia which was achieved was faster with subtenuous block, with an average time of onset being 45 seconds. Peribulbar block took a longer time to achieve. The incidence of minor complications such as chemosis and subconjunctival hemorrhage were more in subtenuous technique, as seen in the graph. 60.7% had chemosis and 26.6% had subconjunctival hemorrhage in subtenuous block. Safer anesthetic techniques had led to the introduction of peribulbar subtenuous anesthesia and more recently topical anesthesia.
1 minute to go.
In this study, we compared the efficacy of subtenuous over peribulbar block. In our study, subtenuous had a low pain score and were they more comfortable during administration as they were unaware of the injection being given. This observation was supported by Parker et al. And Datta et al. In our study, ocular akinesia was achieved faster in subtenuous group compared to peribulbar. The incidence of minor complications such as chemosis and subconjunctival hemorrhage were more with subtenuous anesthesia. This was also reported in Bud et al. In a study. Subtenuous anesthesia is more comfortable in administration and reduces the interval between administration of anesthesia and surgery. The ease of administration and patient comfort intraoperatively makes the subtenuous anesthesia a preferred choice over topical anesthesia for the surgeon. It also has reduced risk of major complication as no sharp instrument is passed into the orbit. Subtenuous anesthesia is safe, effective, and more comfortable alternative technique for phaco surgeries. These are my references pertaining to my article. Thank you.
Can I come in? That was a good presentation, Uma. The only question that I have here is, both being a little blind in the procedures, have you word of caution to people who administer anesthesia through subtenuous?
Yes, sir.
Do you want to give a word of caution?
Yes, sir. The caution was given for both the patients, for both the peribulbar and subtenuous group. They were explained about the risks and the complications. But this.
Do you need to avoid any? It's a landmark that you need to keep in mind. Do you need to avoid any keep in mind the landmarks when you give it?
Yes, sir. It is in the subtenons. We usually give it the infero-nasal quadrant, sir, between the insertion of the muscles of inferior rectus and the inferior oblique and medial rectus, sir, near the watershed area where there's no much blood supply.
Can I ask this question, please? You said the pain score is more with peribulbar than with subtenons.
Yes, sir.
That is because you give the injection over skin, which is not anesthetized, whereas
Yes, sir.
peribulbar is being given under anesthesia with the paracaine. Have
Yes,
you
sir.
ever tried giving peribulbar through the conjunctival way by putting paracaine and then giving peribulbar through the conjunctiva so that it can be comparable technique?
Yes, sir. No, sir, I didn't try that, sir. It was only the proper, the original peribulbar technique, sir.
Okay, thank you.
One more question, Uma Maheshwari. That was a nice presentation. Was ocular massage tried in subtenum?
No, ma'am. No ocular massage was not given, ma'am. Just one compression following the injection, and then whereas in subtenons peribulbar we had given ocular massage. That
So
was actually reduced.
Okay. So do you want to give any suggestion regarding ocular massage? What is the complication associated with ocular massage in subtenum? Okay, it raises the IOP. Okay.
Yes, ma'am.
There
Yes,
is
ma'am.
okay, so it's actually not indicated in subtenons.
Yes, ma'am.
Okay, that was a nice presentation.
Thank you, ma'am. Thank you, ma'am.
Can you stop sharing your screen, Dr. Maheshwari?
Yes.
Okay. I request all the presenters to stop your sharing your screen so that the judges can see your face. Okay, so we are done with the question. So we'll move on to the second paper. Dr. Ansu and John, free paper number 181. You can start sharing your screen, doctor.
So may I start?
Yeah, please. Your time starts now.
Good morning. My paper is on the association of diabetes, diabetic retinopathy, and dry eye. Dry eye disease is a disorder of the tear film due to the deficiency in tears, goblet cell loss, formless metaplasia, and excessive evaporation, reduced corneal sensation, which may cause the damage to the ocular surface. Diabetic patients may exhibit symptoms of dry eye disease probably due to neuropathy, metabolic dysfunction, or abnormality of the lacrimal secretions, which is also influenced by lifestyle changes, change of diet and medications, computer usage, or any hormonal status. So hence, the present study was undertaken to evaluate the stability of the tear film and the condition of the ocular surface in the diabetic patients. So we studied the prevalence of dry eye in patients with type 2 diabetes mellitus with respect to the diabetic retinopathy status. Inclusion criteria included all the diagnosed type 2 diabetes mellitus of all ages and of all durations of diabetes mellitus. We excluded those with systemic disease and local ocular diseases, which were known to cause dry eye disease, chronic contact lens wearers for more than 2 years, those who underwent LASIK surgeries, those who had local or systemic medications causing dry eyes, those who smoked, connective tissue disorders, Parkinson's disease, vitamin D deficiency, and pregnant women. So it was a cross-section study done on 100 patients over a period of 6 months. Informed consent was taken. All the data was collected on patients, and details like H1AC, FPS, and PPBS were recorded. Ocular surface disease index also was done for all the patients. Ocular examination included the visual acuity recording with the Snellen's chart, dry eye evaluation with TBAT and Shermer's test, intraocular pressure with Goldman's appellation tonometry, and retinal status was checked with the IDO. As a result, we found that the mean age of patients enrolled was about 56 years. 44 were males and 56 were females, and the mean duration of diabetes mellitus was 11.614 years. 54 patients showed evidence of diabetic retinopathy. It was mild in 18 patients. 30 patients had moderate NPDR. 6 patients had severe NPDR, and none had PDR. As a result of our study, we had found that the percentage of Shermer's value of less than 10 millimeters in dry eye disease patients was higher in patients with diabetic retinopathy as compared to those without diabetic retinopathy. In fact, we had found that the patients with diabetic retinopathy had 2.98 times more chance of having Shermer's value less than 10 millimeters than those without diabetic retinopathy. Similarly, in our TBAT study, we had found the same, that the patients with diabetic retinopathy had 7.09 chances more chances of having TBAT less than 10 seconds than those without diabetic retinopathy. In our OSDI scoring, we had found that the sensitivity to the light was most commonly reported symptom, while sensitivity to the air conditioning was the least reported symptom. There was a high statistical significance seen between the clinical dry eye testing done by Schirmer's test, TBAT, and OSDI scoring by the questionnaire. We also find a high statistical significance between the increase in severity of dry eye with the severity of diabetic retinopathy, duration diabetes mellitus, and increasing H1AC values. There was no statistical significance seen in different age groups along with dry eye, or even gender was not having any significance.
1 minute to go.
So in this, we can see that there's with increasing dry eye status, there's an increase in the diabetic retinopathy status. And here there's an increase in diabetic dry eye status, there's an increase in duration of diabetes mellitus. So as a discussion, we found that our study had a higher prevalence of dry eye disease in diabetic patients, which could be because of the dysfunction of the autonomic nervous system seen in diabetic patients, along with the tropical area and the dry climate. Dogro also mentioned that he had TBAT and Schirmer's values lower in his diabetic patients seen in our study. Zhang and Bird also mentioned an association between duration diabetes and prevalence of diabetic dry eye disease, which is seen in our study. And many studies also showed between the dry eye disease and the diabetic retinopathy status, which is seen in Ozdemir. Sheikh and Atafi also mentioned the same between H1AC values in the presence of dry eye disease. So as a conclusion, I would like to say that diabetes can lead to ocular surface impairments, and it has to be it has to be treated very well and using questionnaires. And diabetic clinics should use a routine dry eye status questionnaires. Thank you. These are references.
Thank you, Ansu. Thank you for the presentation. What is new and from your presentation that you have quoted different from the literature?
Yes, sir.
Is it in confirmation with the literature reports, or is it something that you have, with your study, you have brought out anything different?
So we had found that in our study as well that patients with dry eye disease were seen in patients with diabetes patients with a higher level of diabetic retinopathic grading. So we could show in that in our study right now. Sir, in this.
Okay. Now, how many of such patients? Is it a significant number that you could probably attribute dry eye to?
Yes, sir. About 54 patients were showing, we had 100 patients with diabetes, sir. 54 patients had diabetic retinopathy status among them. So among them, we found, sir, that there was an increase in dry eye status and there's an increase in the retinopathic status as well. The green suggests retinopathy status, sir. The severe retinopathy status.
So will you like to add tear substitutes as a routine therapy in people with diabetic retinopathy?
Yes, sir. I would like to add tear substitutes and also evaluate the dry eye status among the patients who come to our clinics, the diabetic patients who come to our clinics, sir.
You evaluate only with TBAT and Schirmer's test or with questionnaire?
I did both, all the three, sir. I had done with TBAT, Schirmer's, and the questionnaire, sir.
Okay, and your slides showing this various status of patients with various levels of involvement in diabetic retinopathy along with dry eye, they are quite confusing, not very clear, the slides.
Okay, sir. Sir, this was the pink suggests the patients with no retinopathic changes, which is higher in this patients who had normal dry eye status. So as we go along the dry eye staging, sir,
all the 4 bars were of equal height. Do you mean to say the number of patients in each bar is equal?
No, sir. The patients were not equal, sir. As I mentioned.
Then it should have been different. There should be a difference in the height of the bar.
Yes, sir. This is calculating the percentage of patients who are there under mild, sir. So
you have not mentioned the number of patients calculated here. Then it could have been different. You have not mentioned it. Without that, we presume that it shows the same number of patients.
Okay, sir. Sir, in this slide, sir,
Okay. And also, I would like to say, one of your studies, the studies you have shown, go back, show me the studies done.
Okay, sir.
Yeah. The first one, the before one slide. Yeah. The Seifert et al. You have shown it as 52.8. The 52.8% is the status of dry eye in both type 1 and type 2 diabetic patients. But you have done only in type 2 diabetic patients. Am I right?
Yes, sir. Only type
So,
2.
in the same study, if you see well, in type 2 diabetics, the incidence of dry eye status is almost 72 to 75%. I'm not sure about the number. You please check it.
Okay, sir.
Fine.
One more question if I have time. Jensen sir, can I ask one question?
I'm sorry, ma'am.
Did you include hypertensive patients in your study?
Yes, ma'am. I had included, and there was no association, ma'am. As was seen here, there was no association between the hypertension and dry eye status.
But antihypertensives are known to cause dry eye, like beta blockers and thiazides. And also, like, did you exclude screen time, all those things, confounding factors in your study?
Screen
because
time.
That could be a confounding factor.
Okay, yes, ma'am. Yeah.
Okay. So that was my question, but it was a good presentation.
Okay.
You could have criteria still more.
Thank you, ma'am. So you take into account this, and you can do it in a further better way of doing the paper. So please stop sharing your screen. So I'd like to invite the next presenter, Dr. Vishnu S, free paper number 183. Dr. Vishnu, start.
Yes, sir. So is my screen visible and I'm audible, sir?
Yeah, it's pretty clear and you're audible there.
Yes, sir. Good morning, faculties. I'm going to present about ocular effects of chemotherapy. Chemotherapeutic agents have been used to treat cancer. So just one minute. Chemotherapeutic agents have been used to treat cancer either as a single drug or as a combination regimen. Cancer drugs have great potential to induce acute, chronic, reversible, and irreversible damage in any organ system. Ocular toxicity produced by chemotherapeutic agents is relatively uncommon, as eye is usually considered as a protected site. Hence, many of these side effects go unnoticed. However, some of these side effects, which are potentially reversible and treatable in early stages, turn out to be irreversible by the time they are recognized. Newer drugs are being developed with limited knowledge of ocular side effects. Since the advent of advanced screening and diagnostic modalities of cancer, more people are diagnosed with cancer at an early age. Hence, the life expectancy of the patient is enhanced. So, the monitoring of eye diseases becomes relevant and very important. An ophthalmic baseline examination for all patients planned for multiple chemotherapeutic cycles becomes an indispensable part of patient care. The aim of our study was to identify the potential ocular side effects of anti-cancer drugs in patients undergoing chemotherapy. Materials and methods. A prospective, non-interventional observational study was carried out on 62 patients who underwent chemotherapy for various cancers. Patients undergoing chemotherapy with intravenous route and oral route were included in our study. Other routes of drug administration were excluded from our study. Also, patients undergoing other modalities of treatment for cancer like radiotherapy were excluded. Patients with pre-existing ophthalmic conditions like ocular surface disorders, glaucoma, pre-existing cataract, dense media opacities, also systemic conditions like diabetes, hypertension were excluded. The patients were subjected to baseline ophthalmic evaluation before the start of chemotherapy. All patients underwent complete examination of the anterior and posterior segment with appropriate tests. After a minimum of 3 cycles of chemotherapy, the patients were called back and re-examined, and they again underwent a complete ophthalmic re-examination. Results: 62 patients were enrolled. There were 27 males and 35 females in the age group between 35 and 50. The most common non-specific symptoms which the patient presented following a minimum of 3 cycles of chemotherapy were blurred vision, ocular discomfort, watering, photophobia, and mild red periorbital pain. Among 62 patients enrolled, the spectrum of effects observed in the anterior segment were lid hyperpigmentation, maurosis, dry eye, and blepharoconjunctivitis. Early anterior cortical opacities and posterior subcapsular opacities were seen in patients undergoing treatment for NHL with systemic steroids. Patients undergoing treatment with taxane, especially injection docetaxel for a variety of cancers like breast and ovarian cancers, showed high normal intraocular pressures with no evidence of glaucoma. Also, these patients had no family history of glaucoma. 31 patients who underwent chemotherapy with 5-fluorouracil docetaxel showed evidence of tear film abnormalities, including reduced Schirmer's 1 and T. But 12 of these 31 patients eventually developed blepharoconjunctivitis. Photophobia was common in all patients undergoing treatment with 5-fluorouracil.
1 minute to go.
Patients undergoing treatment with oxaliplatin complained of non-specific mild periorbital pain. Posterior segment findings in some of these included non-specific pigmentary changes in the macula with no clinical correlation. Optic discolour was noted in 28 patients. Discussion. In our study, we just aim to provide a comprehensive experience about these side effects at our tertiary care center. The blurred vision in most of these patients could be attributed to the FP4 and tear film disturbances, which was statistically significant in patients undergoing treatment with 5-fluorouracils and taxane group of chemotherapy. These patients also subsequently developed blepharoconjunctivitis. Non-specific adnexal findings like eyelid hyperpigmentation matosis was found as general side effects in most of the patients undergoing chemotherapy. Pigment mottling changes were also noted in some of the patients. Mild optic discolour was found in some patients undergoing chemotherapy, which could be attributed to the low HP status and poor nutritional status. Low HP also could be attributed to the generalized bone marrow suppression of these drugs. Patients with tear film disturbances were managed with tear substitutes and regularly followed up. I conclude by saying further studies are needed. Newer screening protocols are required. These are my references, and thank you.
Was the sample size, Vishnu, it's a good study, thank you. Was the sample size, did it include, or you had run short of the sample size, actually attributed sample size? Because the very 62 is a very small number to account for these changes.
Yes, sir. We couldn't meet, the sample size was small only, sir. Actually, we were supposed to screen more patients, but
yeah. So the conclusions could, I mean, this study could continue, but anyway, that besides that, I think if you put up the conclusion slide, can you put up the conclusion slide, please?
Yes, sir.
Yes, sir. You've used almost all types of chemotherapeutic agents, no?
Yes, sir.
Yes, sir. So, is there any particular attributable this thing with all these side effects that you mentioned, which is seen more in number of drugs that you related to commonly used anti-chemotherapeutic drugs?
So, patients undergoing treatment with 5-fluorouracil and docetaxel had required tear substitutes.
These patients are post-radiated patients, or they were free of radiation at any point in time in
They did not undergo radiation at any point, sir.
Radiation was an exclusion criteria.
Radiation was an exclusion criteria, sir.
No, was it an earlier patients were radiated for some reason and then continued with chemotherapy? That's what my question.
No, sir. No, sir.
No, sir. No, sir.
I have a question to ask. You said the defective vision can be attributed to the waterlogging or FP4, but yes, you also give, we could see there is a haze in the posterior subcapsular opacification, especially in patients with steroids, and also you said about pigmentation in the macula that has been observed. Why you say they cannot be attributed or the causes as the causes of defective vision? Why you want to say about only the dry eye and watering as the cause of defective vision? I would rather put it as posterior subcapsular opacities and macular pigmentation are more prone to develop defective vision than a little FP4.
Sir, we found more posterior subcapsular opacities were very less in number, sir. So
no, I'm not telling you whether it is less in number or more in number. The defective vision you attribute in your observation as due to the watering from the eye as against as to the dry eye. But I will rather attribute it to posterior subcapsular opacities and macular pigmentation. You could have given the number in how many patients you saw the defective vision and how much was the defective vision. Like that, you could have a little more quantification could have been done. Similarly, in your study, you said about blepharoconjunctivitis in about 12 patients of 31 patients who are taking drug, especially 5-fluorouracil and one another drug.
Yes, sir.
And that percentage out of the 61 comes to less than 24%, whereas you have shown it as a percentage of 40%. I do not know how. If you can see in the slides, you can say the percentage of calculation, it doesn't match well.
Okay.
And one more question, you have not listed out the chemotherapeutic agents you did in the study, you included in the study. It's not exhaustive, and was tamoxifen there? You like posterior segment findings are very less.
Yeah, yes, ma'am.
Even though they are documented in literature, or maybe you could have concentrated only on anterior segment findings. Because some posterior segment findings may be missed without doing OCT. OCT was not done in your study, right?
No, ma'am, we didn't do OCT.
Okay, because subtle retinopathies can be missed in, without doing OCT if you are looking through posterior subcapsular cataract and all.
Yes.
So your result was more of anterior segment complications. If you had done OCT or macula, then you could have picked up more posterior segment retinopathies particularly.
Yes.
Your tail agents, there was not a list. That was my only finding in your study.
Yes.
Otherwise, it was okay. You continue with your study and then publish the results. Okay, thank
Yes,
you.
ma'am. Thank
In
you.
fact, it's a very good study. You continue with that.
Yes, yes, sir. Thank you, sir.
Thank you, Dr. Vishnu. Thank you, judges.
Thank you.
We'll move on to the next person, Dr.Sowmiya Saras, free paper number FP199. Dr. Sowmiya, you ready?
Yes, sir.
Yeah. Start sharing your screen, please.
Sir, is my screen visible, sir?
Yeah, it's visible. Please continue.
Good afternoon, faculties. My paper is on primary pterygium excision with autograft by waste tissue. Introduction: pterygium is a triangular subconjunctival fibrovascular tissue overgrowth of bulbar conjunctiva over the cornea. Most important complication following pterygium surgery is recurrence. Vascular technique associated with a high recurrence rate, whereas pterygium excision with conjunctival autograft carries lower recurrence rate. The major limitation of conjunctival autograft technique is that it cannot be performed in patients with double pterygium, non-glaucoma, and glaucoma suspect patients because of the inability to preserve the superior bulbar conjunctiva for filtration surgeries. In order to overcome this drawback, the conjunctival tissue from the pterygium is used to cover the vas sclera. Aim of the study is to describe a modified technique of using conjunctival tissue graft from the pterygium itself in patients with primary pterygium and to study the outcome. It is a prospective observational study over a period of 1 year among 40 patients. Inclusion criteria of patients with primary pterygium encroaching into the cornea and exclusion criteria of patients with recurrent, atrophic, and early pterygium. Methodology: under peribulbar or topical anesthesia based on patient's cooperation, supervision incision was made at the limbus over the pterygium using conjunctival scissors, and thin conjunctival layer was separated from the underlying fibrovascular tissue and cut to obtain a rectangular conjunctival graft. Subconjunctival fibrovascular tissue was excised completely and scraped the residual tissue with crescent blade. Graft was kept stitched over the vas sclera where it got fixed with autologous blade, and postoperative review was conducted on day 1, 7 at the end of first month, third month, and 6th month to look for graft edema, retraction, and recurrence. This is the video showing our procedure. A superficial incision was made at the limbus. Subconjunctival fibrovascular tissue is excised completely. Residual tissue is scraped off with a crescent blade. And conjunctiva is obtained to rectangular graft is obtained, which is then placed over the vas sclera. The first picture showing preoperative image of a nasal pterygium, and second picture showing 4 weeks postoperative image of a same patient after nasal pterygium excision. Based on postoperative complication, on postoperative day 1, graft edema was observed in 30% of patients and graft retraction was noted in 8 out of 40 patients. At the end of postoperative day first week, graft granuloma was observed in 5% of the patients, and there were no graft recurrence at the end of 6 monthly follow-up. Picture showing postoperative complication of graft retraction and graft granuloma. Discussion: among the various techniques, conjunctival autografting is widely acceptable with minimal recurrence rate. In our study, graft edema was the most common outcome, which could be due to excessive handling of the graft, and graft retraction was the next most common outcome, thought to be due to difficulty in obtaining oversized graft from the pterygium conjunctival tissue. Graft granuloma was observed in 2 out of 40 patients, which may be due to inadequate excision
tissue. Various studies reported that the limbal stem cell acts as a barrier between the conjunctival and the corneal epithelium, and destruction of this barrier leads to growth of the conjunctival tissue onto the cornea. However, adequate size graft was enough to cover both the vascular defect, which still had lower recurrence rate comparable to the other studies. Our study also showed excellent cosmetic results with no recurrence following primary pterygium excision and 6-monthly follow-up. Comparison previously published studies, Kodavar et al. Included 98 eyes of primary pterygium using same technique with fibrin glue, noted a recurrence in 4 out of 98 patients.
1 minute to go.
Rapp et al. Noted used the same technique with 180 degree of rotation, noted recurrence in 2 out of 51 patients. Conclusion, this method can be recommended as a treatment option for patients with primary pterygium having filtering bleb, and also in glaucoma and glaucoma suspect patients wherein the superior bulbar conjunctiva is either not available or may need for future filtration procedure, and in patients with double-headed pterygium where the superior bulbar conjunctiva is not adequate enough to cover both the vascular defect. This method is safe with shorter surgical time and effective with no recurrence reported. These are my references. Thank you.
Thank you, Soumya, for a good study, but I think this has been tried and tested earlier. So my question here is, since you're doing a conjunctival excision of the conjunctival tissue,
yes, sir.
How can you prevent recurrence with the micro cells that are always left there? So it's a 6-month study. It's a longer term study, I think, would give us a clear result. Because this, and another thing is, in your video you put a graph which at the time of placement and anchoring it was rotated. So in line with the palisades, you should have kept the graph straight what you have excised. That I could observe. I may be wrong, but probably you need to let me know if that was done intentionally, or is it something that you recorded and you're not able to show it correctly.
No, sir, it was recorded and.
Yeah, normally we don't rotate the graph. No, we keep it in line. Anyway, those are two of my observations. You could probably, and your presentation could be a little slow. Anyway, it's a good presentation. Thank you.
Thank you, sir.
You don't rotate the graft, yes or no?
No, sir, we didn't rotate the graft.
Then why do you detach the graft? Why don't you just replace it with the graft pedicle, that nasal caruncle area? Why you want to cut it out?
Making the incisional graft, the conjunctiva tissue is getting retracted towards the medial canthal section.
Why it should retract? Why? See, we are cutting the conjunctiva exactly at the limbus. Am I right?
Yes,
You are not cutting it shorter. Only the pterygium on the cornea is being excised, and you excise the subconjunctival elastotic tissue. In fact, you are debulking the pterygium. So in fact, you will have a little excess of conjunctival tissue. Why should you then cut it, de-anchor it, then place it? Instead, why don't you just dry the base and place it nicely? It could have been giving a much better aesthetic appearance and also a good anchoring value, and it will not get detached. Am I clear? You can try at least in some patients. One, because you have removed the subconjunctival degenerate tissue. But only thing, whatever tissue that you have left sticking to the back of the conjunctiva, that can again go in for degeneration, and a pterygium can recur. That's the problem. That's what I think can be a problem here. But if you scrape properly the underneath the conjunctiva and debulk it properly, take away all the subconjunctival degenerate tissue, decent amount of cautery, so that bleeding is still kept there and some serum oozing is there. Then replace the conjunctiva just as a flap, and then it will nicely stick. That's what my opinion is. You can try it at least in some cases.
That was the same question I was also about to ask, the same suggestion, because your 6 months time follow-up is needed for watching for recurrence. And again, why do you cut it instead of pulling it and doing
just leaving it there? Yes,
just leaving it. And autologous serum, if there is blood already present, it will stick. There is no need to put separately autologous serum. That was the same question I wanted to ask. Anyway, it was nice, Dr. Sowmiya. Okay, all the best. Thank you.
Thank you, judges. Okay, we'll move on to the next presentation. Next presentation will be by Dr. Priyadharshini, free paper number 206. Dr. Priyadharshini, you ready?
Yes, sir.
Sir, am I audible? Is the screen seen, sir?
Yeah, you're audible and the screen is visible. Please
So
proceed.
can I start, sir? Good morning, judges. I'm presenting on correlation of 17 beta estradiol with Maberman gland dysfunction and dry eye disease in postmenopausal women. Dry eye disease has a high incidence in postmenopausal women due to altered hormonal changes. MGD is one of the leading causes for evaporative dry eye. This study aims to understand the concentration of serum beta estradiol with the MGD dysfunction in postmenopausal women. This is a cross-sectional comparative study. The dry eye group had 50 cases of postmenopausal women who are symptomatic, and the normal group had non-symptomatic patients. Inclusion criteria: postmenopausal women above 50 years of age, and the patients who are symptomatic. Exclusion criteria: patients who had undergone hysterectomy, had a history of hormonal replacement therapy, known case of Sjogren syndrome, hormone-dependent neoplasia, or any known case of anterior segment diseases. Methods: the patients underwent dry eye assessment and slit lamp examination. Only the Mabum quality and expressibility of the Mabum were taken for the grading of severity, as the other signs are not specific. The MG evaluation was done according to Brown-Fuchs scoring as shown below. 2 ml of venous blood was collected from the subjects at 8 a.m. After overnight fasting and sent for ELISA analysis of the estradiol hormone. According to the results, in age-wise distribution, in the dry eye group, the majority of the patients were in 60 to 70 years of age group. And according to the OSDI questionnaire, in the dry eye group, 24 patients were in mild, 16 in moderate, and severe in the 10 patients. In the mean value of the was higher for the symptomatic dry eye groups. For OSDI, it was around 29, and for tear breakup time around 6, and for ocular surface staining around 7. In the dry eye group, as shown in the graph, the patients had altered Mabum expressibility and Mabum quality. According to the serum estradiol level was higher in the dry eye group, which was 30.90, and the normal group was 16.02. And the value of estradiol also increased as the severity of the MGD increases, and a significant p-value of 0.005 was obtained. Discussion: in general, the normal premenopausal estradiol value is from 30 to 400 picogram per ml. In the postmenopausal period, the estradiol value comes down to 0 to 30 picogram per ml. In our study, we found it was 30.90, which is on the higher side of the normal range. As the severity of the MGD increases, it is associated with the altered Mabum secretion and altered Mabum expressibility, and patients showed symptoms. These were associated with the higher levels of estradiol. Similar findings were found by studies conducted by Vesura et al. And Guaglan Shen et al. But studies done by Blanco, Globieski, and Gagliano et al. Did not find any significant association. In our study, we found a significant association of 0.005. Hormonal replacement therapy done in postmenopausal women for dry eye have shown inconclusive results. They may or may
1
not
minute to go.
Dry eye symptoms. Altered Mabum expressibility and Mabum quality in dry eye patients in postmenopausal women is associated with altered Mabum gland morphology, like increased lipid layer thickness, which is due to the altered sex steroids. In our study, ELISA was used to measure the serum beta estradiol, which has some limitations. Serum estrogen is also confounded by factors like diet and the health of the patient, which was not considered. Thus, we can conclude higher serum estrogen will alter MGD morphology, will lead to evaporative dry eye in postmenopausal women. I like to conclude saying newer analytical technique has to be developed for measuring the sex hormones for a higher specificity and sensitivity rate. Specific questionnaire can be developed for MGD for research purposes, and further research is needed to understand the varied effects of sex hormones on dry eye disease, and the the beneficial treatments that can be obtained. These are my references, and thank you.
Thank you, Priya. It was a study that interesting study. But this is both subjective and objective.
Yes,
the
sir.
study. So, have you compared the results of your objective evaluation with the subjective questionnaire that the patient fills up? And is there a correlation, or you are only attributing your objective results to the serum estradiol? Is that what you're trying to tell us?
Sir, I with the question, I evaluated everything, sir, and classified the patients according to the severity to the MGD stages, and I found the estradiol value was on the higher side, sir, as the stages increases. So it was comparatively, it did prove to be higher, sir, as the stages increased.
Okay, thank you.
If sir, can I ask a question?
Yes, ma'am.
Sir, Rajendra Prasad, sir, if you want, you ask, sir, then I'll ask.
Sir?
Proceed, ma'am. I'm just observing.
No, this, since you have taken estradiol, but now the focus is shifting on testosterone, and you said the higher value is 30 picogram per ml, no, in postmenopausal.
Yes, ma'am. Yes, ma'am.
And the normal value in premenopausal is between 330 to 400, right?
Ma'am, premenopausal is 30 to 400, and postmenopausal is below 30, ma'am.
Yeah. See, so all premenopausal women don't have dry eye.
Yes, ma'am.
But you said that the dry eye people had higher estradiol levels, which was 30.
Yes, ma'am.
So in premenopausal women, it's around 400.
Yes,
and
ma'am.
those people don't have dry eye. Okay, but so nowadays, actually, the shift has been towards testosterone, which is responsible for decreased lipid, that is for lipid secretion.
Yes,
so if your study had included both beta estradiol and testosterone levels, it would have been more relevant.
Okay.
Okay, that's what I wanted to mention.
Should have been a complete.
Yeah, it would have been more complete.
Okay.
That's a very good observation, and really, I hope you take up that in your if you continue with the study.
Yes, sir. Yes, sir.
Thank you, Jesus.
Thank you, sir.
Thank you, Dr. Priyadharshini. So we'll move on to the next presentation. Next presentation will be by Dr. Sharanyaa Krishnamoorthy, paper number 207. Dr. Sharanyaa?
Yes, sir. Am I audible, sir?
You're audible. Can you, Dr. Priyadharshini, stop sharing your screen.
Yes, sir.
Can I start, sir?
Just a minute, let us stop sharing. Yeah, now you can share your screen, Dr. Sharanyaa.
Can you able to see my screen, sir?
You can start now. No, we can see your screen.
One.
Try screening. Try sharing again.
Can you see, sir? Can I start now?
Yeah, please.
1 second, just. Can you able to see, sir?
Yeah.
Yes, sir. Good morning to all the panel members present here. Myself, Dr. Sharanyaa Krishnamoorthy. We have done a study on prevalence of aqueous deficiency dry eye and common ocular surface changes among salt workers. There are several occupations which have hazardous chemical, physical, biological effect on eye. Salt production is one such hazardous occupation. India is the third largest salt producing country in the world and second largest salt producing state is Tamil Nadu. This study was done in assessing the common ocular surface disorders among salt workers. The aim of the study is to find the prevalence of aqueous deficiency dry eye and ocular surface changes like pinguicula, pterygium, conjunctival cysts, and tumors among salt workers in Maracana. It is a cross-sectional study which was carried out around 2 months among 253 salt workers with minimum exposure of 6 months after taking informed consent. The workers with systemic diseases and other ocular surface disorders were excluded from the study. The data collection was done using a pre-designed questionnaire. The workers involved in the study were examined in a room with a maximum illumination. The ocular examination was carried out by torch as it was a field study. Then they were shifted to a dark room to perform Schimmer's test 1 and 2. The most common ocular surface changes we found were pterygium, aqueous deficiency dry eye, and pinguicula. The prevalence of pterygium was 39.52% and aqueous deficiency dry eye was 38.3% and pinguicula was 29.64%. We have taken few parameters to assess them like gender and occupation. In salt workers, there are two groups of workers. One is salt pan worker and dry salt workers. Whereas salt pan workers, they work in the outdoor under the sunlight for longer duration, whereas dry salt worker is the work which is an indoor work. And with years of experience and hours of working per day, we have divided them into two groups, more than 10 years of experience and less than or more than 6 hours per day of working. With pterygium, the male were predominantly affected, around 46% males were affected. And with occupation, the salt pan workers have been affected more and it is highly statistically significant. Even with experience and the time group, More than 10 years of people and more than 6 hours per day workers have been affected more. Around 45% of people have been affected with pterygium. When coming to aqueous deficiency dry eye, even in this, the male were predominantly affected compared to females because these workers are the workers seen in salt pan workers. So even here, the salt pan workers are affected more, and even with increase in experience and increase in hours of workage, around 41% of people were affected with aqueous deficiency dry eye.
1 minute to go.
The limitation of this study, it was a field study and the examination was carried out with only torch. So only basic dry eye parameters could be looked into and it was only Schimmer's test. Aqueous deficiency dry eye, pterygium, pinguicula are the most prevalent ocular surface disorders among the salt workers. Among the identified ocular surface changes, pterygium was found to be the most predominant one. Salt workers exhibit more ocular surface changes compared to dry salt workers due to excessive exposure to salt and sun. Salt dust has been observed as a major etiological factor for pterygium along with ultraviolet radiation, which is a well-known cause. Thank you.
That was a good study. Yes, sir. I think Dr. RP, sir, please go ahead.
Sorry, sir. Sorry to disturb you. See, you said that there is a gender difference between male and female,
yes,
either
sir.
in the outdoor work or indoor work, or whether it is with everything. In every parameter, the males outscore the female. What could be the reason? The work is the same. The exposure is the same. The surrounding is the same. And then why there is a difference between male and female?
Sir, but generally, if we take this dry eye study in various studies,
I'm not bothered about generally.
No, sir, gender. No,
why?
sir.
Why there is a gender? What could you attribute the gender difference here?
Here, because they are working more in the sunlight, sir. Those people
but both are working. Then why the males are more affected than females?
What I thought was because they two groups are there now, so the salt pan and dry pan. The salt pan workers are the male, mostly the only male workers
you are
are
right,
there,
ma'am. Salt pan workers are there, and then dry places workers are there. In both, the male are outscoring the female. Why? Both are working in the same place, same number of hours with the same exposure. Why one particular sex should be more developing, more prone to develop this problem? Is it because females shift duty?
No.
Maybe. Any other reason? One thing, ma'am. And again, you have given a detailed study of the pterygium, the number of pterygium, whether it is in male, female, which type of work they do, with the number of years, hours working, with years of experience. And why you have not bothered to tabulate like that with pinguicula also? All you have said is there is an incidence of pinguicula to the tune of 29.6%, whereas pterygium is 30 and odd. You have taken so much pains to differentiate pterygium, whereas never bothered about pinguicula. Why?
Sir, we have done the detailed same study only.
But you have not written anything about pinguicula. You said just
sorry, not to mention
just
about
one line. It is 29.6% of cases developed pinguicula. Nothing else. Why?
No, sir, I have done, but I didn't put it in this screen because
it should have been. It should have been.
I'll do it, sir. Next time I'll surely I'll do.
Okay, thank you. Try to find the reason for the difference between male and female.
Sure, sir. Sure, and I will get back to you.
Please, sir.
Yes, sir.
Yeah, I think my question was the last part of what Dr. RP sir was asking. Why only pterygium was focused more than most of the other things?
Sir, we found only majorly three things, sir: pterygium, pinguicula, and dry eye. Because I put pterygium and aqueous deficiency dry eye tabular column. Pinguicula because it's like similar, sir. So I thought why to say one second. It's sorry for that.
Order of appearance or the what was happened in your study, or is it that you overlook pinguicula and concentrate?
No, sir. When I'm in the paper, I've written it detailedly about pinguicula also, sir. While putting this, I thought once again it's like repeating. Maybe I should have done that. I should have put it. Sorry for that.
Well, this is very relevant because today occupational injuries in the non-organized sector is being taken up, and I think that these salt workers are exposed and they are not accounted, or people are not responsible for their this thing. I think it's a very relevant study. Anyway, thank you so much.
Thank you, sir. Thank you.
And one more question. Why did you put in the title only aqueous deficiency dry eye?
And we couldn't do tear breakup time there because we have taken slit lamp everything, but we doesn't have those convenience to do there, ma'am, in that field. So we couldn't do tear breakup time for them.
Okay, but
so
you didn't elaborate.
Yes, ma'am.
Yeah, there is no need
disease.
to split the hair and look inside. You can just say dry eye. Presence of dry eye among Salpan workers or something.
Okay, sure, sir. Taken, sir.
Yeah, because your title itself started with that, but you didn't elaborate on that. That is right. Okay, but otherwise it's a relevant topic.
Yes, ma'am. I placed about aqueous deficiency dry eye, ma'am. Actually, only pingacula I didn't mention.
Not that. Why did you choose only aqueous part? I wanted.
That's what, ma'am. Because my tear breakup time. I didn't do my tear breakup time, ma'am. That's why.
No, but the mechanism for pterygium, the mechanism in salt workers includes both evaporative and more of evaporative.
Yes, ma'am.
Sharanyaa, there's one more last question that I want
to
ask.
Yes,
I wanted to.
Yes, sir.
Is that duration of time exposed, because sir was asking about male and female,
yes,
duration of time exposed is more for male, or is it an equal duration of time that you attributed males to having more of these?
No, sir. Duration of work is equal for males and females, sir. But the males working under the sunlight and salt dust are more compared to females, because it is more of hard work. So that salt pan workers are mostly males, sir. These dry pan workers are mostly females.
See, but there is a difference there in percentage in both.
Yes, sir. Sir, I'll find out and I'll let you know for sure.
You have to.
Yes, sir. Sure.
That's
sir.
a very sharp point to me. Why there is a big difference between male and female with other parameters being normal?
Yes, sir. I'll find out, sir. Thank you, sir. Thank you.
Sharanyaa, you can make a note of it. And,
yes, sir. Sure.
Study and you can just it's a nice one. Okay.
Thank you, sir.
Stop sharing your screen.
Yes.
Small note to all the judges. Sir, please note that next presenter is not there. Dr. Jayasri. Dr. Vaishnavi?
So
yes, sir. Yes, sir.
Not
yes, sir. Dr. Jayasri is not available. So we'll move on to the next presenter, Dr. Mugundan.
What is the number of that Jayasri?
It's FP251.
Okay, that is not there. Okay.
Not there. So we are going to the last presentation of the day by Dr. Mugundan, free paper 307.
So 1 minute before I go, I can leave that page blank in my marks.
Dr. Atik?
Yes,
can I leave that page blank in my marks submission?
Yeah, you can move to the next one, sir. There's a next
Fine, ma'am. Thank you.
Dr. Mugundan, your screen is. You can start your presentation. The time starts now.
Good afternoon, respected faculties. Thank you for giving me an opportunity to present my paper on assessment of knowledge on eye donation among students in a tertiary teaching hospital. India holds second place globally in blindness with prevalence of 0.45%. Corneal diseases remains the important cause for visual impairment and blindness in the developing world, with corneal transplant as the mainstay of treatment. It is estimated that around 270,000 eye donors are required to perform 1 lakh corneal transplants per year in India. There is a lack of knowledge, awareness, willingness about eye donation amongst public, especially among youth. This study aims to assess the same. The aim of the study is to assess the awareness, knowledge of eye donation among medical paramedical students in a tertiary teaching hospital. Methodology, it's a cross-sectional study done from March to July 2019 at Sri Ramchandra University. A total of 448 students were taken. A semi-structured questionnaire was given to the students. The questionnaire consisted of general information regarding the student, various aspects of eye donation, information and awareness regarding eye donation, willingness for pledging and criteria for eye donation. The statistical analysis was done with the SPSS software. Inclusion criteria, out of 448 students, 199 students were pre-final MBBS and rest were paramedical students, which included allied health sciences, nursing, nutrition, physiotherapy and trauma care management. Exclusion criteria, patients who completed their courses were excluded. Results, all 448 students who participated in the study submitted their response. 157 students were male and 291 students were females. In this study, all students were aware about the existence of eye donation. 64.3 students know that there is a shortage of donor in our country, and 19.2% of students knew that patients having communicable diseases cannot donate their eyes. And 77.7% of students knew that the eye should be retrieved within 6 hours after death. And 21.9% of students knew that whole eye will be removed during eye donation. 75.7% of students knew corneal blindness as the major cause of blindness in our country. 75% were aware about the existence of eye bank, and 95.3% of students think that it's their responsibility to spread awareness in the society. Among the source for knowing eye donation, mass media played an important role, which accounted for 62.1%, whereas doctors accounted for only for 2.7% in spreading about eye donation. 81.5% of students were willing to pledge their eyes, whereas 18.5% were not willing to pledge their eyes. The main reason being the religious cause. The other reasons were facial disfigurement, family objection, and a few of them don't know where to contact for eye donation. Discussion: blindness due to corneal causes can be treated only if we have enough number of eyes. In our study, all students were aware about eye donation, and mass media played an important role, which was about 62% in spreading awareness. It's similar to study done by Muthukrishnan et al. And Krishna et al. 64.3% of students knew that there is a shortage of donors in our country. 95.3% of students consider that as the students is their responsibility to spread the awareness about eye donation.
1 minute to go.
Only 18.5% of students were not willing to donate their eyes, in which a religious reason seemed to be the major cause. A study done by Anita et al. Showed that unwillingness to separate eyes from the body was the reason for denying pledging of eyes. Based on the above results, we can state that students have good knowledge, awareness, and willingness for eye donation. Conclusion: in our study shows that both medical and paramedical students have good knowledge and awareness and willingness for eye donation. They can act as messengers to create awareness about eye donation in the community. Students must be encouraged to conduct awareness camps along with other community groups, as they are the future healthcare providers for the community. Considering the percentage of awareness created by doctors, it's our responsibility to ensure the importance of eye donation. These are my references.
Sir, Happy sir, please go ahead, sir.
I feel ashamed that we teachers make a very short percentage creating awareness among students. I really feel sorry for that. In fact, it's a good study, nicely done.
Thank you, sir.
Yes, sir. Thank you. The Mugundan is a good study, sir. But I think we have only captured the literate and the urban population. So I think probably rural also it matters. If we probably go there, in spite of all the awareness that media has created, I think we need to find out how much of the rural population know about this awareness, because it's a good amount of eyes that you could probably get with all the religious taboos that are set with it. So I think this could also be taken up further to include a rural population at some point in time and their awareness.
Among policymakers, they must make it a point to teach students, especially medical as well as non-medical community, about eye donation and how much it can go to help a blind man. A little more interest can be shown by us teachers in the teaching curriculum. That's what I feel.
Yes, sir. The study, like you had mentioned, the awareness by doctors, even for pre-final students, didn't they tell that the doctors told them like it was only 2%? Yeah, MBBS students at least would have told.
They are like, telling mass media only. Really,
yeah, they're telling mass media only.
Insulting, yes.
Yeah, that was one point which was like,
hurting.
Yeah.
Yes, ma'am.
Thank you.
Thank you.
Thank you, sir.
Thank you, Dr. Mugundan. You can include, I think, more of non-ophthalmology doctors in the study, and then you can see how the reports are going to be. Thank you. So we have come to the conclusion of our session. So we are pretty on time. So Dr. I think we are finished the session on time and given it to you. So thanks, special thanks to the judges. It was very informative. Your knowledge of judging the papers, the questions, what you asked is very nice. Thank you so much, sir, for sparing your wonderful time with us. And I request all the presenters to make a note of all the points which has been told by the judges. Take care and then do all this as a publication. Try to send this all to our TNOA journal. So we'll be happy if you can make it as a publication. All the best. So results will be announced by 3 o'clock. I request everyone to watch the YouTube link. It will be shared in the groups. Over to Dr. P. Thank you so much, Atik. Thanks for the opportunity.
Thank you, sir. Thank you, judges and moderator.
Thank you, Dr. Atik. Thank you, Mugundan sir, and thank you all the team who made this available and possible. Thank you. Thank you for considering me. Thank you.
Thank you.
On behalf of all of the judges, I think it was a very good session that it is innovative. And I thank Atik and Dr. Jayanthan and Dr. Pratibha for coordinating and making this fruitful session.
Thank you,
all the
thank you.
Thank you.
Yeah. Thank you for
Thank you,
having me in
Subha.
this session.
Thank you, Suhas sir.
Yeah,
Thank you,
okay.
Rajendra sir.
Thank you,
Thanks
sir.
to the entire TNOA team.
Thanks, Shubha ma'am. Thanks, Suhas sir. Thanks, Jayantan. Thanks, Pratibha. And Vaishnavi, thank you so much for coordinating it so well. Thank you.
Thank you, sir. Thanks to all the judges and the participants. Thank you.
Goodbye.
Thanks, participants. Without you, this show would not have happened. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Sai, we can conclude the session, Sai. Is anyone from the Neurotech team is it?
Yes, doctor. Balaji from Neurotech is available. I can't hear you, doctor.
Thank you so much.
You're welcome.